that's really a testament to what Christy and Dare has been able to do. So not something I take for granted that we get to be here talking about this on a Saturday evening, especially for Bart, who I'm glad is here. I'm happy to come maybe right after the last discussion for a few reasons, but I want to first just say a few words about retinitis pigmentosa, or RP, to make sure as we hear that we're all on the same page about it. And I think we probably are as a starting point, but just in case. So RP is a really genetically and clinically heterogeneous condition where we know there are at least 80 different genes where if they are have disease-causing variants, they result in photoreceptor degeneration. In some parts of the world, RP is actually called rod cone dystrophy, reflecting that rods are classically impacted earliest, followed by cones. And from the perspective of individuals with RP, this classically results in a loss of night vision, a deterioration of peripheral vision, and often good central vision mediated by cones until later stages of disease. And I tried to throw in a few classically in there because even among the most common RP-causing genes, there are very diverse patient experiences, and I think that is probably even more so true for the RP that accompanies adult refsum disease. And as I think about, as clinicians, how people like Bart and I follow patients with RP, we have a growing number of really sophisticated ways to look at how ongoing photoreceptor degeneration affects things like visual field, affects the actual electrical amplitudes of the rods and cones, and then, at its core, what is happening anatomically. But I think a common experience of a patient, common doesn't mean everybody, is that year over year, if you ask them what's changed, what are you doing differently? Often they will say, well, maybe things are a little worse, but I'm not sure. And again, not everybody's experience, but often what we hear. So against that backdrop, here we are talking about the RP that comes with adult refsum disease. And the importance of this is big, right? And a wonderful community survey that Dare did, this was right at the top of the kinds of concerns that individuals with adult refsum have. As we think, though, about some of the things Joe discussed that we hope are in the future, about the things that Dr. Fassbender just discussed in terms of how can we manage phthanic acid right now, there's some big challenges with regard to making sure we translate that effectively into actually helping retina and retinal prognosis. So one big area of concern and just limitation is the data we have right now. There is, and I'll get more into this in a second, we just don't know enough. We don't have enough contemporary data on how RP and refsum changes over time. We don't know at this point in time, is there any kind of genotype-phenotype relationship? There was a wonderful paper from Gavin Arnaud and Moorfield recently that hinted that there may be for some individuals, but across the entirety of individuals with adult refsum, we don't know that. And as has been alluded to already, how spikes in blood phthanic acid, spikes or chronically high levels, how those directly impact the retina and how lowering them impacts the retina are also pieces of data we don't have. So I will come back to this in a moment because it is what the Vision and Retina Working Group has been talking about. I just also want to spend a moment, though, on something that also came up this morning and I think is a common patient experience, which is just the delay in diagnosis. And therapy is only worth something if it's getting to people who need it in a timely way, right? And so I think as many individuals with adult refsum present first to ophthalmologists, there is a need and opportunity for education to enable earlier diagnosis. And I think there have been cultural changes and practice changes, for example, a lower threshold to ordering genetic testing for individuals who walk into a retina clinic. Still a ways to go here. That's maybe not part of a 5-year research scope, but still very much something that I appreciate Global DARE is thinking about. So just to kind of highlight what we could know more about. One is that although there are wonderful, very high quality case series on retinal disease and adult refsum, they are old. So, the newest large studies are at least 20, 30 years old. And that matters just because of how technology has changed and the kinds of things I take for granted when someone walks into my clinic are not how people were followed 20, 30 years ago. So if we think about how we would follow a treatment, the age of this data is a limitation. And just to hammer this home, this is maybe like a 6-month outdated PubMed slide, but searching for something refsum and retina related, you get very little in the recent past. This did exclude Gavin Arno's paper, so this is not be all end all, but it just highlights that there is a paucity right now. So maybe we'll just back up a step to say that we had some really good discussions as the Vision and Retina Working Group. Bart was part of that. Gavin Arno was part of that. Jose Sahel, who has had a huge impact on the retinal degeneration field in general, has been a part of some of these conversations. And Gavin Arno, who was at Moorfields and now is based in South Carolina. So we had rich discussion. Diane helpfully collected this in a very long document with, I think, 10 different points, which points to all the areas of opportunity and need. And so I took some editorial prerogative to consolidate these down into what are some very significant strategic priorities, thinking about how do we position ourselves to having the knowledge and foundation needed for trials in the coming years. So maybe you're not surprised to see this as number one, but to have a better understanding of the natural history study of RP or rod cone degeneration in adult refsum disease. We need to, as a community, understand things like how fast is somebody's visual field changing? How is that linked to their serum phitanic acid, or how is that not correlated, right? We just heard Anne's comments about an individual who did have, ongoing, state-of-the-art efforts to control phitanic acid and still went legally blind. So what is the relationship, and is there a moment in time where intervention might be more impactful from a retina perspective? What are the earliest, and I'm not going to go through these point by point, but just to touch on some, what are the earliest symptoms? I think anecdotally, thanks to the Boston Center of Excellence, seeing a number of individuals, especially earlier, I think what they come in with is a little different than what somebody with garden variety retinitis pigmentosa comes in with regard to visual symptoms. So capturing that helps us to identify people earlier. And then, I highlighted all of the ways we measure retinal disease for a reason, because I think we have become increasingly aware as a community that although we can measure all of these things, how do we make sure that we're also keeping track of what is most meaningful to the patients providing that data, and what is most impactful for them as we think about ways to address retinal disease. Florian will be speaking later, but we also had a meeting of the vision and neurology group together, and the very important topic came up of how do different sensory deficiencies, vision and hearing, interact with neuropathy, and is that linear, or additive, is the sum more than the parts, and how do we understand that when we assess natural history and also think about treatment? I think there are challenges here in terms of having a natural history study. Bart and I are part of many international natural history studies for RP and other retinal diseases, so this is a pursuit that we are very familiar with. One challenge is just numbers. For a potentially clinically heterogeneous condition, what number of people do you need to have to make sure that you are capturing a representative swath of the data? One of the organizations that Bart and I are involved with has an umbrella study with some gene-specific natural history studies on it, and the lowest enrollment there is 10 people. You can't have a gene-specific natural history study under that umbrella study unless you have 10 people. Even that is a pretty small group to form any very definitive conclusions from. And then what about duration? I told you that RP is slowly progressive. How many years do we need to follow people, and how do we get the funding for that period of time? And how do we make sure that every single test we do in that period of time is impactful so that we are being efficient? And then that kind of natural history study really ideally leaves you positioned to what I think should also be high on the strategic priority lists. That's using natural history data to say, okay, if we have an intervention, here are the things that we are going to measure. Here's why we think that they are good clinical outcome measures, and here's how they're going to measure to patients. The clinically meaningfulness piece, it is a big one. And maybe it's nice here that we have a clear biomarker of phytanic acid. That's not the case for many genetic types of RP, whereas a retina community, we have the challenge of proving to regulators that slowing of something by a certain amount is actually clinically meaningful to people who may not perceive that slowing of change. And as we think about outcome measures, there are statistical properties, there are clinical properties, and it would be great to be in the luxury of the position to address some of those questions. And then this is why a group like DARE that has so many kinds of expertise is important. I think we still need to understand exactly how elevated phytanic acid is damaging to photoreceptors, and understanding that may also open up new pathways that, in tandem with the genetic therapy, in tandem with just lowering serum phytanic acid, are there other pathways we can intervene on that would ultimately be protective to the retina? So I'm giving some of the other groups some work here, and I appreciate all the effort that's already been done. So I didn't have many slides because I think discussion is probably where most of our benefit will be today. So I will pause there.